halfway between junior and senior resident, James Pan, who did his undergraduate work at Carnegie Mellon. He got his medical degree from Stanford University, and he came here. He's very interested in trauma and critical care, and he did design technologies when he was at Carnegie Mellon. Without further ado, James, would you like to share your story?
Thank you, sir, for that very kind introduction. I will get this going.
And I believe Dr. Hauptman was going to say a few words of.
Oh, go ahead, Dr. Hauptman.
Is that right?
Oh, come on.
Dr. Hauptman, were you here?
Oh, yeah, no, everything Rich said, I agree.
You have a great lineage. Now, don't let us down. Do great things, okay?
All right, so I'll start by talking about pediatric tether cord syndrome. So this is a study that we did over the past couple of months looking at the 6-year experience of pediatric tether cord syndrome with the emphasis on complications and the risk factors for complications that has been done in children for the past couple of years. So let's see. So as an introduction, so tether cord syndrome, it's a syndrome. It's a constellation of symptoms characterized by neurological, MSK, and often urinary symptoms. It has an incidence of about 0.25 per 1,000 births. A lot of the symptoms have to do with the etiology of the spinal cord being under traction, being that it is tethered to something lower than where the conus terminates. So you have a low-lying conus that is pulled down by some sort of mass or some sort of lesion. Usually the etiology of tether cord is secondary to something like a fatty or fibrous phylum, which is by far the most common etiology. To more complex malformations like split cords, dermal sinus tracts, lipomas, myelomeningocele, lipomyelos, and myelocystocele. Surgery is indicated for children with worsening neurological symptoms, or those we do it as a prophylactic measure to prevent other complications like scoliosis from developing. The surgical technique involves a single level lumbar laminectomy, intradural exploration, sectioning of the phylum, and resection of an intradural mass if it is associated with one. So at Seattle Children's, it's a very busy tertiary referral center. We looked at the retrospective review of consecutive tether cord operations from July 2014 all the way up to December of 2020. We looked at all patients that underwent CPT 6300, which is laminectomy for tether cord release, and all detethering operations of all etiologies were included. The primary outcome that we wanted to look at was any complication related to the surgery. A couple definitions. We defined simple and complex etiology. Simple etiologies were defined as those not associated with a dural or fascial defects, such as fatty or thickened phylums, lipomas, or dermal sinus tracts, not associated with an intraspinal mass. And then we also have another definition called operative complexity, simple versus complex. We called it a complex operation if it involved any of the following: plastic surgery systems, placement of a drain, duroplasty, or usage of the operating. So for the entire cohort, we had 242 consecutive tether cord operations. Mean age was about 75 months. Mean operative time about 182 minutes. They stayed in the hospital average of 5 days with pretty good follow-up for 493 days. The median time to complication was 11 days, so that was well captured within our standard follow-up of 2 weeks for our wound checks, which is pretty good. I put the median up because the mean was skewed a little bit due to a tremendous outlier, a complication that occurred at 252 days, resulting mostly from a prolonged hospitalization. If you look at some of the binary characteristics, about 16% of them had pre-existing CSF diversion, 16% of them had a prior detether operation, 55% had a significant comorbidity. We had a pretty loose definition of significant comorbidities. Those like bacterial kids, even with simple phylums, we considered being more medically complex. About a third had plastic surgery assistance, 12% of the drain placements, 35% we used a laser for, 7% went to the ICU, and we considered 48% of them as simple operations. So things like fatty phylums, thickened phylums, simple dermal sinus tracts, and so forth. Here are what the etiologies of the operations looked at like, a majority of which were simple tethering, simple detethers like fatty phylums. Others were some of the more common complex detethers were lipomyelos and myelomeningocele, and then we also had some sprinkling of dermal sinus tracts, lipomas, and others which included split cords and myelocystoceles. So the overall complication rate of any kind along the entire cohort was 10.7%. If you look at the complication rates in just the simple detethers alone, it was 3.5%, which is much more in line with previous reported rates in the literature. And the complication rates in complex operations was as high as 17.5%, which again is similar to those reported in the literature in the past. If you look at the types of complications, CSF leak was by far the most common, followed by pseudomeningocele, and then wound healing issues. Some of these kids had pre-existing shunts, especially the myelo kids, and if the operative field gets contaminated with blood, that can also cause a shunt malfunction. And then one had a sacrodecubitus ulcer as a result of a very prolonged hospitalization. If you look at the univariate analysis of the kind of the things that are significant between those that had a complication and those that didn't have a complication, surgical time, hospital length of stay, plastic surgery assistance, drain placement, usage of laser duroplasty, and operative complexity were all associated with increasing complication rates, which makes sense since more complex operations tend to occur in more medically complex patients, and they stay in the hospital longer and more prone to complications. Things that weren't associated were things like BMI, weight, follow-up, pre-existing CSF diversion, prior detethers, comorbidities, or ICU admission. If you put all these significant covariates in a multivariate logistic regression analysis, for all cases, you see that hospital length of stay, usage of the laser were associated with more, predictive of more complications, and drain placement and duroplasty, drain placement was actually protective against complications. If you look at just complex cases, meaning cases with high operative complexity, surgical time was associated with increased complications, but plastic surgery assistance and drain placements were actually significant protective factors. And I think that makes sense because for these complex operations, if a plastic surgeon is involved, it usually ends up in a more robust closure and protects against things like CSF leak, pseudomeningocele, and so forth. Drain placements was also protective, and I think that makes sense since that does offload pressure off the wound and also acts as a protective agent on the if you compare simple versus complex operations, things that were significant were BMI, the weight at surgery, the age at surgery, surgical time, hospital length of stay, whether they had a pre-existing CSF diversion or not, although I think that's more reflective of the etiology. Prior detethers, similarly, the complication rate, again, like I mentioned earlier, was much lower in simple operations versus complex operations. And the median time to complication in both simple and complex cases were pretty much within 2 weeks, so it's well captured within our follow-up. However, it's not statistically significant, but for complex operations, if they did have a complication, it tended to occur at an earlier time frame. Some of the etiologies of simple versus complex operations, those that required more operative complexity, of course, were associated with more of the complex etiologies, things like lipomyelos, myelomeningocele, dermal sinus tracts, and lipomas, whereas those were with simple operative complexity were associated with more simpler etiologies like your fatty phylums and thickened phylums. So in conclusion, this study examined the practice of patterns and outcomes of 242 consecutive pediatric tethered cord operations as a busy tertiary care center. The overall complication rate was 10.7%, but if you look at simple detethers, it was only 3.5%. The median time to complication was 11 days, which is well captured within our standard follow-up. Things that weren't associated with complications were age, BMI, weight, whether they were admitted to the ICU or not, pre-existing CSF diversion. Things that were associated with complications were longer operations, hospital length of stay and usage of the operative laser, and things that this study suggests were protective against complications were drain placement and plastic surgery assistance, especially for complex cases. So some practice recommendations that I think can come out of the study is that I think all complex tether cords should be evaluated by a plastic surgeon for a more robust closure. Routine placement of lumbar drains for complex operations, and this is actually something that we just started doing just a couple of months ago for all complex operations where it required a resection of intradural mass, like lipomyelos, myelomeningocele redo operations. We now do we place a lumbar drain for 3 days to essentially protect the wound. And of course, I think all kids, especially complex operations, nutritional status, comorbidities, and medications which can hinder wound healing should be optimized with consultation with their pediatrician and also with the plastic surgery team. There was actually a Delphi consensus of best practices that was formulated by a group of pediatric neurosurgeons for complex tether cords to avoid complications. And the practice patterns at Seattle Children's mostly pretty much follows this to a T, but at the time they did not recommend routine drain placement. They actually said it was not necessary. However, our recent practice changes and the results from this study suggest that this might be something that might be worthwhile doing for more complex operations to avoid further complications. So I'll leave it at that. I'd like to thank Dr. Hauptman for mentoring me through this project, and of course all the surgeons and staff at Seattle Children's Hospital for taking care of the children. Thank you. Dr. Ellen Mogan, I think you're muted.
Hey, James, it's Sam. Great job on that. I think that really characterized our practice well and the changes we're trying to make. So that's super good job.
Are there any questions or comments?
Now, James, why did you not classify redos as a complex operation?
A lot of the redos were actually fell in the complex group. A lot of the, I wouldn't say, so a lot of the redos, if they involved something like a duroplasty, a lot of them, in fact, most of them involved like a duroplasty of some kind, assistant of a plastic surgeon. So I would say most of the redos actually fell under the plastic, under the complex category.
It just seems like that's the predictor of complexity, and then the others might be subsumed under the redo banner, because it certainly proved to be correlated with complications.
Yeah, I think so too.
Yeah,
sorry.
Go ahead.
Yeah, James, thanks for putting that together. Did we look at separately the kids who had what the rate of CSF leak were kids with myelomeningocele who already had a pre-existing shunt?
It's captured in the data. I don't think we got a specific rate from it, but it should be easy to calculate. We did capture the data, which can allow us to calculate that.
Okay, because I don't know that I'd necessarily put a drain in a child who already has a shunt, but it would be interesting to see what our actual CSF leak is for children who have pre-existing shunts.
All right.
Hey, James,
So next one is Gil Barros. Okay. Gil, you ready?
Yeah, I'm ready. You guys see my screen okay?
Yeah, and James, thank you very much. We had thousands and more questions, but we just didn't have the time. I see your screen fine. So Gil went to, as impressive as it is, he went to Johns Hopkins where he got a degree in biomedical engineering, and then he got his master's of physiology and biophysics from Georgetown before getting into Thomas Jefferson Medical School, Sidney Kimmel Medical School, and his lineage before he became a PGY4 at the University of Washington. So Gil, tell us who you're working with, and maybe they can say a note about you or about the project.
Great. Yeah, Dr. Levitt and Dr. Kim are the mentors of the project, and I've been working closely with them on this.
Mike, any words?
Just that Gil looked at some of the work we were doing in the lab and came up with an independent hypothesis and a plan to do it entirely by himself. And it was very impressive. He came with a very fully formed idea that you'll see here.
So in other words, he deserved his degree from Johns Hopkins in biomedical engineering.
More than, yes, exactly.
Exactly. Thank you. Go ahead, G.
All right, thanks. So I'm going to be talking about the work I did for the R25 grant, modeling the effect of hemodynamic changes on the endothelial transcriptional profile of cerebral aneurysms after endovascular flow diversion. So just a quick intro on flow diversion for those that aren't endovascularly inclined. So the main goal is to induce thrombosis within the aneurysm sac. The stent is placed within the parent vessel. It's a low porosity, higher metal coverage stent that's placed across the aneurysm neck. And about 80% reach complete occlusion by 6 to 12 months. And that number increases to just over 95% at 5 years. But there's still a percentage of patients that don't get their aneurysms occluded and they need retreatment, or their aneurysm grows, or they suffer a complication. So these kind of basic facts led me to think about, why do some of these patients need retreatment, and how can we make better endovascular devices? So there's two ways to look at it, or two ways that have been mostly established of looking at the effect of flow diversion on aneurysms. So from the computational flow dynamic perspective, so the reduction of hemodynamic stress within the aneurysm dome has been shown to be necessary to induce thrombosis and sustained occlusion. And some of the parameters that Dr. Levitt's lab and Dr. Kim's lab, as well as several other groups have looked at, are wall shear stress and wall shear stress gradient, as well as the blood inflow rate into the aneurysm. And specific differences have been shown between patients that have known, successful, and failed. Another way to model this is through a more biologic model, so the actual endothelial cells. So Dr. Levitt's lab has published on this in 2019, and they looked at untreated aneurysms. So they got the 3D spins from the angiograms and made 3D printed models from that, and then subsequently made negative models. You could see here in panel C, showing the proximal parent vessel, the aneurysm itself, and then the distal parent vessel. And then through these negative models, through the lumen of these, they were endothelialized, and subsequently RNA analysis was done to look at different vascular remodeling factors at different areas along the vessel and the aneurysm itself, and seeing how the different the blood flow and hemodynamic patterns affect those. So integrating all of these things together, I came up with a hypothesis. So hemodynamic changes within the aneurysm dome after flow diversion should directly drive the endothelial cell transcription and protein expression, resulting in differences between patients that have successful treatments and failed treatments. So getting more into the details of the project. So my goal is to develop aneurysm models, actual physical models like the ones that I showed you before, to quantify the response of the endothelial cells. So I'm going to be focusing on the endothelium for this project, and seeing how the change after flow diversion affects the endothelial RNA and protein expression. And then I want to use that co-localized data, so both the CFD data, which we already have, and the biologic data from the endothelial cells, to see how the patterns change between successful and failed treatments. So this here is a model that, the first model that I seeded, this was last month. I worked with Sam Levy and in the South Lake Union lab, and we I seeded my first model. So you could see here, this is a zoomed in photo of the aneurysm dome. This is a culture media, and then it may be hard to see on there, but there's tiny little white circles everywhere, and those are all endothelial cells. And somehow I was able to manage to get those things to stick. So my goal is to get 12 unique cases, half with successful treatments and half with failed treatments, and insert the actual flow diverting stent device that was used in that case into the model that you see there, and then seed that model with human carotid endothelial cells into each for subsequent analysis. So the cell growth media will be driven through the model via a pulsatile pump, and you can see the setup here of an example. So this is the aneurysm model here with an inflow and an outflow tract, and the media will be driven through the model to simulate the patient-specific blood flow waveform from their CFD that we already have from prior studies. And then we'll biopsy the dome of each model and perform RNA and protein analysis of the endothelial cells to see what the differences are between the failed and successful treatments. And from that, we should be able to identify potential patterns between the two. And this is the master and his apprentice at work there. So some just anticipated preliminary results that I can see. Decreased levels of ADAM-TS1 and NOS3 have been shown to correlate with lower velocity, lower wall shear stress, and lower wall shear stress gradient in prior untreated aneurysm models, and that was seen in Dr. Levitt's prior work. And I want to take that one step further and see how that changes with flow diversion. So I suspect that if there's a successful treatment, that decreases in those parameters should lead to also decreases in the levels of those factors. In the failures, I suspect there will be either less of a change or no change at all. But I really want to look at other inflammatory factors. There's so many different targets that we can have, both for a drug or the device itself, to develop new and improved devices in the future to increase the rates of aneurysm occlusion and prevent rupture and growth. Just want to thank Dr. Levitt, Dr. Kim, Dr. Ellenbogen, Dr. Oderman, and Sam Levy who made all this possible. Thanks.
Thanks, Gil. Any questions, Mike? Anything you wanted, comments you want to make?
Just this is an example of it. Rather than bench to bedside, this is an example of bedside back to bench. So we're taking real world patient data in the form of positive or negative treatment outcomes and actual physiological measurements. And then we're looking back and trying to bridge the gap between computer simulations and actual biology. And I think that's the novelty of this approach. It fits well with Gil's experience in bioengineering. We're working pretty closely with other collaborators, Alberto Aliceta in mechanical engineering and Ying Zhang, who is a bioengineer at South Lake Union. So a very, very multidisciplinary effort that Gil is heading up going into next year for his R25.
Hey, Gil, it's Christoph. I have a quick question for you. You're obviously modeling both the structure of the aneurysms as well as you're seeding with endothelial cells, and I assume that it's a cell line. But is there any way for you to also sort of take systemic factors into consideration, such as flooding this with interleukins for making a more inflammatory environment, or sort of paying attention to different platelet function that these patients are going to have?
Yeah, for this specific model, I wanted to, really focus on the endothelial cells. I think things can get a bit confounding and muddy the water if you infuse a bunch of different factors. I've looked at that as well, because there's also different, structures of the blood vessel itself, like smooth muscle and other, attachment factors that play in. But I think for this, I want to simplify it to just the endothelial cells. They have shown to be, major secretors of different factors that have led to vascular remodeling, but in all different kinds of vasculopathies. So that's a good point, that there's kind of other things at play here. But for this model, I didn't want to include too many variables.
Okay.
And
Thank
Gil's
you.
being kind. That's the talk answer. The unofficial answer, Christoph, is that what you're describing would be very helpful, but is extraordinarily difficult. And it's really difficult to model platelet activity without anticoagulants, which then changes all sorts of aspects of the simulation. So if we had a better way to do that, we would. But that's a very, very difficult, complex model. So, but Gil's answer was better for presentation.
A quick question. Any thoughts about the phenotype of aortic endothelial cells compared to cerebral endothelium?
So, go ahead, Gil.
No, I mean, I think, we're using carotid, which is very close, obviously, to where we're going to be modeling these aneurysms. So I think that's kind of the most adjacent that we have available. But Dr. Levitt, if you have any experience with aortic, I've only seen umbilical vein and carotid being used?
Yeah, you can get endothelial cell lines from just about anywhere, including intracranial. Carotid are probably the most hardy. I think the question that Dr. Mayberg is getting at is the relationship between aortic aneurysms and cerebral aneurysms. There is an association. There's of patients with cerebral aneurysms, there's a higher incidence of aortic aneurysms. It's something that's been looked into a little bit, probably not enough, but something that phenotypically is pretty interesting. And one could see extending this methodology to just do the same experiments over again with different phenotypes of endothelial cells and see how they react. That's actually a pretty interesting idea.
All right. Well, that is a good discussion. Thank you, G. Without further ado, Dr. Kate Tobin Carroll is going to give a talk about her work on subarachnoid hemorrhage. Kate, by way, we have forgiven her, but she did go to Princeton University and get a degree in psychology and neurosciences, and it shows. And then she was one of the elite medical students at the University of California, San Diego, where she did medical school, who received an NIH grant, a TL1 scholar, to get her master's degree. And she got a master's in clinical research with coursework focus on biostatistics, epidemiology, and clinical trial design. She graduated from University of San Diego, and she is currently with us, and we're very proud to have her. And she was on call last night, so be easy on her, but I'm sure she's going to do a wonderful job. So tell us what you're doing with Dr. Levitt, Kate and Kim.
Yeah, thank you for that kind introduction, sir. I have been working with Dr. Levitt and Dr. Kim and the entire SANS group on looking at depression rates and treatment of depression in aneurysmal subarachnoid hemorrhage. And so this is a bit of background, and then some preliminary data and discussion of kind of future directions where we hope to take this project. I have no disclosures. So as way of introduction, aneurysmal subarachnoid hemorrhage has an incidence in the United States of about 14.5 per 100,000, 14.5 hospitalizations per 100,000 people per year. This incidence varies worldwide from about 5 to 15 per 100,000, depending on where you're looking. The mean age of patients afflicted is in the mid-50s, and women have a higher risk than men. Overall, we are doing a better job of treating patients with aneurysmal subarachnoid hemorrhage. Case fatality rates are falling, and patients are having improved functional outcomes with time as our management of the complications of aneurysmal subarachnoid hemorrhage, such as hydrocephalus and vasospasm, improves. But with improved survival and improved functional outcomes, patients are experiencing more and more less visible complications, something that has been termed post-aneurysmal subarachnoid hemorrhage syndrome, very similar to traumatic brain injury. Sequela includes disorders of emotional, somatic, and cognitive issues. And really characterizing the emotional disturbances that these patients face is a very high rate of new depression. This affects about 30 to 40% of aneurysmal subarachnoid hemorrhage patients. The risk of developing a kind of new index depression is 2.5 times greater than normal matched controls. And the depression does not start immediately after the injury. Patients remain at risk of becoming depressed months to even years after their hospitalization for subarachnoid hemorrhage. Risk factors for developing it have been identified as higher Hunt and Hess scores on initial presentation, pre-existing psychiatric illness, both a pre-existing history of depression, but also other illnesses, younger aged patients, patients with a history of substance abuse, and patients with new functional disability. This may sound obvious, but studies have shown that a new diagnosis of depression is associated with a decreased quality of life for these patients. And patients who face a new diagnosis of depression have decreased rates of returning to work in the months to years after hospitalization for subarachnoid hemorrhage. There are some studies beginning to look at treatment of this phenomenon. Cognitive behavioral therapy has been shown to help, but this is quite time and resource intensive. There are some retrospective studies looking at the use of pharmacologic therapy in this population, but as of this point, no prospective trial looking at pharmacologic treatment of depression in aneurysmal subarachnoid hemorrhage patients. There is very good background, however, within the post-ischemic stroke literature on why this might be a valuable tool in treating this phenomenon. Post-stroke depression is a pretty well-studied phenomenon at this point, and the literature very much so supports that SSRI use is a safe and effective treatment. Just establishing kind of some of the relevance. Post-stroke depression has a very similar prevalence. About 30% of patients, or a third of patients, will develop post-stroke depression. It has a similar risk factor profile, so stroke severity, a history of psychiatric illness, cognitive impairment, and physical disability are all associated with a higher risk of developing post-stroke depression. Interestingly, there is evidence that the development of the depression may have a biological etiology or pathophysiology underpinning it. Some of the data that supports this includes that patients with anosognosia can still develop post-stroke depression. It is seen in animal models. They can have behavioral disturbances concerning for post-stroke depression. It can be seen in patients with very mild strokes and even TIAs. And some of the hypotheses about what is causing the predilection for developing it include cerebral perfusion reduction, higher cortisol levels, and lower levels of neurotrophic factors, as well as amygdala volume reduction. As opposed to the aneurysmal subarachnoid patient population, there are actually now multiple randomized controlled trials on the use of SSRI, both in treating post-stroke depression as well as in preventing the development of post-stroke depression. Patients who are treated with SSRIs have a decreased odds of developing post-stroke depression. Also, if that treatment is for over a year, they have decreased odds of developing it. Treatment with fluoxetine has been shown to decrease the rate of developing depression. It has also been shown to improve motor function recovery. And that is even when you control for the treatment of the depression. And if that isn't enough to kind of motivate and or validate the reason behind treating this or addressing this sequela, post-stroke depression is associated with a higher overall mortality in stroke patients. And so given all of this, we elected to pursue a single institution, randomized double-blinded placebo-controlled trial looking at the rate of depression in post-aneurysmal subarachnoid patients when treated with fluoxetine versus placebo. So this patients undergo one-to-one randomization into the drug arm of the trial, or they can be enrolled in an observational arm of the trial. If they are in the drug trial, the drug arm of the trial, they either receive fluoxetine 20 milligrams daily or a placebo. And again, that's double-blinded to provider and researchers as well as to the patient. We are enrolling patients either at the time of discharge from the hospital or at 21 days post-ictus, whichever comes first. They get a baseline assessment at enrollment, and then again at 6 weeks, 6 months, and 12 months, corresponding with their clinical follow-up for their aneurysms. Inclusion criteria include adults. We started enrolling in October of 2019. We screen for moderate or severe cognitive impairment with the MoCA assessment. We are excluding patients with a history of psychiatric illness at this point, and patients must be English speaking. And they are being evaluated with a battery of emotional, physical, and kind of social support assessments that are well validated and used elsewhere in the literature. So at this point, we have screened 74 patients, 38 of whom were deemed eligible and 7 of whom were enrolled, some in the observational arm and some in the drug arm. At this point, we have baseline data for all of them and are continuing to collect the subsequent time points. At enrollment, our population has mild depression. They have a high degree of social support, kind of moderate energy or fatigue issues, moderate role limitation, and a slight sleep disturbance. But as discussed previously, post-aneurysmal subarachnoid hemorrhage is definitely a phenomenon that can develop in a delayed manner. So discussion and future direction. The results of this and the kind of topic has really broad applications in aneurysmal subarachnoid hemorrhage long-term recovery as we continue to do a better job of both saving these patients' lives and giving them a better overall functional outcome. It is really important, and kind of the burden is on us to also start to think about how to give them back not just their life, but the lives that they were leading before this happens. Some of the additional things that we can look at and that I hope to look at are cost effectiveness of treating post-aneurysmal subarachnoid hemorrhage depression, looking at whether there is improvement in overall functional recovery if we do treat psychiatric and mental health sequelae, looking at correlation of the complications of subarachnoid hemorrhage, such as vasospasm and hydrocephalus, in the risk of developing depression, and whether modifying some of the kind of in-hospital trajectories influences the rate of developing some of those mental health sequelae. And so the next steps are, we are working on a proposal for funding for a multi-center randomized double-blinded placebo-controlled trial, looking at studying this, and the results of our single institution study will very much so inform the trial design for this one. As you can kind of see, we've had slow enrollment and recruitment of patients into the trial, and hopefully by expanding to a multi-center, we'll be able to get this data and kind of practice change out into the clinical care field sooner. I would like to acknowledge everybody at the Stroke and Applied Neuroscience Center, Dr. Levitt and Dr. Kim, Doe, and Jade. This work is obviously not my own, and really represents a tremendous amount of work from a lot of people. So thank you.
Yeah, this is great work. And as you know, if you go into a diabetes clinic tomorrow, 80% of the folks in that clinic will have some sort of mood disorder or depression. It's just part of the chronicity. What's unique about this one is that this is a more acute, less chronic sort of condition. So my question for you, Dr. Kate Tobin Carroll, is, did your master's degree in medical school and design of clinical design, clinical trial design help you with this project?
Yes, absolutely. I mean, I think that it just helps knowing what questions to answer, what some of the issues are that are going to come up, how to kind of talk about logistically how to organize these things, what like I said, what obstacles you're going to face, what your issues with enrollment and recruitment are going to be, how to get patients to follow up. So yes.
Good. No, I mean, I would imagine it would be an enormous help for a project like that. That's why I asked.
Can I make a statement? It's interesting because you see the same thing with glioblastoma. There have been large studies from UVA, from Michigan, looking at depression in glioblastoma, and it's more than half the patients get clinically depressed. And no one has ever looked at if you have antidepressants, such as SSRI that you're talking about, will that change? And the other thing is the patients that get depressed have statistically shorter lengths of survival. So if any of the residents are interested in getting the same study going for the glioblastoma patients, that's something that's never been done and I think is worth pursuing. Jason Rockhill and I, about 5 or 6 years ago, actually submitted a grant to do it, and it didn't get funded, and we kind of ended up just dropping it, but just throwing that out there.
Great.
Yeah, Dan, hey, this is Christine McDonald. That's a universal construct in a lot of different disease states is the comorbid mental health conditions that follow. And so, Kate, bravo. I mean, really great work here. I think you're tapping into something that's really important, not just for survival, but for quality of life. My one comment and question to you is, because these individuals obviously are going to be evaluated diagnostically so much with the imaging that's available, have you considered looking at the known structures in the brain that are involved, and have been identified to be involved in depression, to understand for those who may appear as resistant, treatment resistant, is it really just because, the drug's not working, or is it because they just don't have the anatomy for the target for that drug to hit? Just wanted to put that out there if you guys are thinking about ways to enrich and understand the interaction, because your point is well taken. Pathophysiologically, we know that there are alterations in the brain itself that can impact mental health conditions.
That is an awesome question. My understanding from the post-stroke depression literature is that they have done imaging, and in like meta-analyses of the data looking at whether there is a lesion site association with it, it has not borne out that there is.
Yeah. So, and I know we're short of time, so I apologize for cutting you off.
Yeah, we can talk about it.
Is to say, when there's a stroke, and subarachnoid hemorrhage is a great one as well, when there's an altered shift, when the brain itself has shifted, that other regions obviously can be more distally affected. And there's newer stuff out there that would suggest that, that amygdala, those hippocampi, the connections within the frontal lobe that we know are involved in depression, even if it's not the focal deficit, the area of infarct, could in fact also be impacted, just not as the frank global change that you would normally be looking at. So just as a plug for, looking in the future, you may want to look for some of those subtle changes that may explain why some of your patients may not have the best response, God forbid, to the fluoxetine Prozac treatment that you're doing. But bravo, because yes, big problem going for it. So thanks for considering it.
No, I love that. Thank you.
I'd like to make a quick comment. When I was at GW, we did a very large study of patients with skull-based tumors, and we found that depression was very common in almost 10 to 15% of the patients. So it probably does have some correlation with any kind of neurological or neurosurgical treatment that has long-term effects. The question that I have is that you're obviously pursuing treatment with fluoxetine. How about counseling for these patients? Because fluoxetine long-term use also has side effects, and withdrawal of the drug can have other problems. So what about pursuing counseling, psychological counseling for these folks?
Yeah, absolutely. There is a role for that. And there is at least one study that has looked at the role of cognitive behavioral therapy in helping support these patients. And I think that, the best data that we have about mental health suggests that pharmacologic and therapy combined have very good outcomes. So I don't think that pharmacologic treatment, precludes the use of therapy in this population at all.
Great.
I'm suggesting that the counseling should be therapy.
Yeah.
Got it.
Yeah. We could go on for hours with this discussion, and I really appreciate everybody's comments, and I apologize that I'm cutting everybody off, but let's go on to the next one. Jessica Katie Eaton is being very polite and waiting. The sister to Kate Tobin Carroll is Jessica Eaton, who, and I love doing these introductions because we forget how impressive, we know how impressive our residents perform day to day, but their lineage and their background. She just went to the University of Louisville, where she got her degree in physics and English. I bet you didn't know that. And she went off to the University of Louisville for her medical degree, at which time she won a Fulbright Fogarty fellowship in public health. And if you remember, when she was a sub-I, she gave a talk on Malawi and the work she did in Malawi. Of course, now she is a resident in our program. So we're looking forward, Jess, to what you're talking about today. Thank you.
So I'm going to talk about extraarachnoid subdural hematomas, which is a project that was born of an observation and then a question that was asked during actual clinical patient care. And I think that most of us have been presenting a consult in the morning, and Dr. Chestnut has observed that that is purely extraarachnoid. And so we noticed kind of anecdotally that these patients seem to do better than a classic subdural hematoma patient. So Mike Meyer and Maddie kind of did the legwork to initially get this together. And then we did this analysis to determine whether what we were noticing was true or not. So as we all know, when you're the junior resident on-call at Harborview evaluating a trauma patient, one of the most important things is to determine if they need urgent surgery for decompression. One of the most common reasons that they need that surgery is for a mass lesion like a subdural. I think we also all know that in general, subdural patients don't do great. A study from our institution several years ago showed an overall mortality of 16%. And then in the elderly, which is going to be relevant to this talk and the unique population we're talking about, the mortality at 100 days is actually 30%. So these patients have a unique clinical picture that we're going to talk about in some detail, but as I said, we noticed that they tend to have a better outcome than patients that have subdurals that violate the arachnoid. I think that you are probably thinking that that's fairly intuitive, because if the subdural doesn't violate the arachnoid, the parenchyma is entirely preserved. So it makes sense that they would do better. But I think the point and what we will show here is that they come in looking worse and their shift is worse and the thickness of the hematoma is worse. And even despite all of that, they do better than the standard patient. So these are examples of CT scans that have subdural hematomas that are entirely extraarachnoid. It's something that you can see on CT, but you can also confirm it in the operating room. If you take them, you can swipe the hematoma right off, and then the arachnoid's intact and the parenchyma looks fine. It'll just have a dent, and then hopefully the brain comes back up. So the clinical picture you usually see is that it's an older patient with a low impact trauma. And in fact, we had to exclude patients younger than 50 from our comparison cohort because our sample of patients of interest, and none of them were younger than 50. So it's usually, an older person with a ground level fall, which again, if you think about it, makes sense because they had enough trauma to, get a cortical vessel or a bridging vein or something like that to create the subdural, but not enough impact to create the shear injury or the contusion or those other types of things that we see in like young men that got their brain trauma during car accidents. When they come in, they very often have a really poor neuro exam. And the story that I think a lot of us can tell is you're the junior on call overnight, you see this patient, they have a huge amount of shift, they have a lot of comorbidities, they're older, they're extending, you call your chief and you talk to the family and you kind of counsel them in a pessimistic way and encourage them not to pursue surgery. And then you round in the morning with your chief and the patient is following, which is why we call this presentation Patients Who Die Then Talk. It seems to be that the initial compression from the subdural causes the poor exam, but the brain seems to adapt in some way that the patients wake up by, the next several hours. And that is likely why they do better too, because as we've said, the parenchyma is preserved, and other than the compression, all of their function is largely there. So we recorded patients prospectively and then retrospectively reviewed their medical records. So when we saw a patient in the morning who had this on CT scan, we would just make a note of their MRN. And we came up with 50 patients. Actually, there's 49 because one of them didn't have appropriate follow-up. So 49 patients that were gathered from January 2015 to December 2016. And then to put together a comparison group, we used the TRACK TBI database. So the only criteria when we pulled those patients was that they had to have a subdural and something else. So intraparenchymal hemorrhage, subarachnoid hemorrhage, something like that. Like I said, we had to exclude any patients younger than 50 years because our entire cohort was older than 50 years. We did propensity weighting to make the populations more similar since we were using a large database. And then for the analysis, we did a logistic regression. We controlled for midline shift so that we were looking at comparing apples to apples. And then another thing we did to kind of validate what we expected to be saying was we took the crash prognostic model, which is a model that was put together based on the crash trial that looked at steroids and TBI. And it has a few different things that you put in: patient age, extracranial injuries, pupillary exam at admission, and a few other things. And it tells you that based on this population, with the demographics that you put in, what the expected mortality should be for that population. And then we were able to compare that to the actual mortality that we saw. And then the primary outcome we used was the GOSE score at 2 weeks. And that was just a limitation of the data that we had and the data that's in the track TBI database. So our group of interest was 49 patients. The control group that we used was 246 patients. As I said, they are an older group than the classic trauma population. And then they did tend to be more male. Their GCS at admit was a little bit better in our group, but none of these differences were statistically significant. The midline shift in our group, this is actually the only thing that was statistically significant, was worse, 7.2 millimeters versus 2.7 in the control group. And then when we put the factors from the two patient populations into the crash model, the expected mortality in the track control, the track TBI control group was 22%, and the predicted mortality in our group was 21%. The actual mortality in the control group was 18%, which is relatively close to the 22%. And then our mortality was 10%, which is less than half of what the crash model predicted. And then when we did the logistic regression, this first number here, this is without even controlling for midline shift. So it's just a little bit shy of statistically significant, but the odds ratio for a better GOSE was 2.1. And then when we adjusted for midline shift, it is very significant. We actually got an odds ratio of 5.7 to have an improved GOSE at 2 weeks. So I think the important points here are that these patients come in. I think when we think of subdurals, we think of midline shift and thickness of hematoma and how these are predictors for very, very poor outcomes. And I think it affects the way we counsel patients. I think it affects the way we counsel patients even more in patients that are over 50 years old and have some comorbidities, and that we might paint a bit of a pessimistic picture for the family and kind of talk to them in a way that might discourage surgery. But I think that if you know that they have an extra-arachnoid subdural, it should, I think it should affect the way that you speak to the patient and maybe encourage them towards surgery a little more, just because we know that based on this data that the outcomes are actually dramatically better than they would be if the subdural violated the arachnoid and they had other brain injuries. And that's all I have. I will take questions. I should say, I want to say thank you to Dr. Chestnut and Bono, and then Dr. Temkin and Jason Barber helped with the stats. Also, a huge thank you to Mike Meyer and Maddie, like I said, who did some of the legwork at the beginning to kind of get this going.
Great, thanks, Jess. Any questions for the folks?
Hi, Jessica. Just had a question. As some people, some of the subdural might be quite intuitive if it's extra-arachnid, but what like objective criteria did you use to define that? As some might be a little more like ambivalent, and between observer might be sometimes difficult to decide if it's extra or extra-arachnid. So what are the objective criteria you use to define your patient population?
Yeah, we just did based on really looking at the CT scan, and like I said, operative confirmation. I think you make a good point, and it would probably be a good idea to in the paper kind of delineate how to do that for institutions that don't regularly see this many subdurals and notice the difference. But there are, I think if you look at the CT scans, it's like fairly clear. You can just see that the brain is completely compressed, and there's absolutely no traces of subarachnoid hemorrhage or anything like that. But I understand what you're saying, and I think it'd be a good thing to spell out.
Yeah, I mean, it's something it's a concept, to be honest, we didn't talk about in my residency or another institution. So I think it would be good to brought up a more definite criteria, especially if you want to
More
publish
practical.
that.
Yeah.
Yeah.
Yeah, and I think
Define-
when you look at the track database, you know, they record like 40 different CT scan findings, and this is something that's not on their list either. So
Once you start looking for it, you will see it, but it isn't something for which we look, as you just said. So to some extent, it's really not too hard to differentiate. You just look for subarachnoid blood, but that's simply not something we do. We see a big mass lesion and we think a subdural is a subdural.
Great. Thanks, Jess. Appreciate it.
thank you all.
All right. I think Dr. Boop is next, correct?
Yes, sir.
All right. So as Scott starts sharing the screen, Scott did his undergraduate work at Trinity University, where he majored in neurosciences. He went off to get a master's of public health at the University of Memphis, and then attended medical school out at the University of Arkansas, and he did his work while he was.
Dr. Ellenbogen, you're very faint. You're very quiet.
I'm sorry.
Oh, yeah, that's much better. Thank you.
Okay, I had my hand over the microphone.
Oh.
So Scott did his work on global health issues when he was at the University of Arkansas, and why don't you tell us what you've done?
Sure. Thank you for the opportunity to present today. I'm going to be discussing some research that I performed along with Ariana, looking at first-time seizure following ETV in patients at Seattle Children's. And this research was recently published in Child's Nervous System earlier this year. So big thank you to all the Seattle Children's attendings for helping to contribute to this. So a little bit of background. There's been a lot of research looking into the relationship between pediatric hydrocephalus and the development of epilepsy. Obviously, there's a wide array of etiologies that contribute to pediatric hydrocephalus, and there's been evidence that these pathologies contribute to a varying extent whether a patient will go on to develop epilepsy. And there's been a lot of conflicting reports in the literature as well. Obviously, very interested in looking at the literature regarding post-operative seizures following shunt placement as well, given that that's obviously the primary durable treatment for hydrocephalus in pediatric patients worldwide. And so there's additionally been a wide body of literature looking at postoperative seizure rates following shunt placement. And again, with a lot of varying findings in the literature. Overall, the postoperative seizure rate following shunt placement varies in the literature from reports between 12% to 50%. There's some evidence that cortical irritation from the catheter itself may play a role in postoperative seizure development in studies that have looked at this with patients who've had EEGs following shunt placement. But those same studies also even say that there are patients who develop seizures with the site being primarily contralateral to the catheter placement. So even the studies that are reporting this relationship admit that there's conflicting results. And so one of the things that we wanted to look at, given that sort of finding, is whether ETV may have a increased or decreased risk of seizure rate, as it is one of the emerging alternatives to shunt placement for treatment of hydrocephalus, especially in pediatric patients. With the thought that, maybe the cortical irritation from a shunt catheter might be even larger that effect may be even larger in patients who receive ETVs, given that the cannula size for that is even larger than a shunt catheter. And this is something that's not really been well studied. There's really only been one good study comparing the rates of seizures following ETV and shunts, and that was published a couple years ago. But it was a pretty narrow focus in its population, which it was a paper only looking at post-infectious hydrocephalus in infants in Uganda, so not exactly generalizable. So the hypothesis underlying this paper is that rates of seizure following ETV may be higher than what is reported following shunt placement in the literature, given that theory about the cortical irritation, and that we may find varying seizure rates following ETV depending on the pathology that's underlying the cause of hydrocephalus in our patients. In order to look at this, we did a single institution retrospective review from May 2014 to December 2019 of all patients undergoing ETV with or without concomitant choroid plexus cauterization. We included all patients who are less than 21 years of age who had at least 1 year of follow-up following ETV, and excluded all patients who had a prior shunt, who required a shunt within 7 days following ETV, and who had a documented prior seizure disorder. The factors that we looked into primarily were late versus early postoperative seizure, and we defined those as early as seizure occurring within 7 days following ETV versus late, obviously being after 7 days and up to 1 year following ETV. We looked at whether there was an association with choroid plexus cauterization or not, concomitant choroid plexus cauterization. We looked at whether there was a patient's required conversion to a shunt within 1 year, whether that changed their risk of seizure. Looked at whether any patients received prophylactic anti-epileptic drugs, as it's not really the standard of care at Seattle Children's. And spoiler alert, none of the patients received prophylactic AEDs in our population. And then we looked at their underlying etiologies of their hydrocephalus to see if there was any association. We performed a few different tests, Mann-Whitney and Fisher's test, to look at some of the descriptive variables, as well as a univariate and multivariate logistic regression. Unfortunately, couldn't really adjust for confounders in the multivariate regression due to our sample size. Just to go over our results briefly, we had 60 patients that met our criteria with a slight male predominance. Average age at ETV was about 6 years, and nearly half of them underwent concomitant choroid plexus cauterization. The pathologies that contributed primarily to hydrocephalus were posterior fossa and tectal tumors, which is about a third of our patients, and then aqueductal stenosis and other posterior fossa malformations made up the rest of the bulk, with one patient who had post-infectious hydrocephalus and none who had post-hemorrhagic hydrocephalus. Our main findings were that about 7% of our patients, so 4 patients overall, ended up developing early or within 1 week seizure following ETV, with 5 patients developing them late, and 3 of these patients crossed over from the early to the late group. So, and of those, 1 had a Chiari-1 malformation, 1 had a medulloblastoma, and 1 had a posterior fossa cyst. So no clear association there with etiologies in terms of risk of long-term seizure. And as I stated earlier, no patients received prophylactic AEDs. And overall, there was no association with underlying etiology, no association with age or gender. And 3% or about, and three patients that did develop early seizures went on to develop late seizures overall. And our ETV success rate was about 63%, with 37% requiring conversion to a shunt within a year. So some of the implications and impacts of this paper, again, as I mentioned, the etiology of post-shunt epilepsy and seizures are not really well understood, with conflicting reports in the literature despite extensive study. ETV is an emerging alternative that's being used more and more for CSF diversion in pediatric patients, but really the seizure risk associated with the procedure is not well studied or well understood. And so that's our reason for wanting to look into it. And our study indicates that the seizure rate may actually be less following ETV, so about 7 to 8% in our patient population versus what's reported in the literature between 12 and 50% following shunts. And then early postoperative seizures may be indicative of development of seizures later, with about 75% of the patients that did develop an early seizure in our cohort going on to develop further seizures and epilepsy. Obviously, some of the limitations of our study is that it was a small single institution retrospective analysis. We did not do any direct comparison between shunts and ETVs, and then no patients in our cohort had hydrocephalus secondary to IVH, which is one of the main etiologies that contribute to seizures in pediatric patients with hydrocephalus. And so obviously there, that raises the sort of next steps. Obviously there need to be more direct comparison studies between shunt and ETVs in terms of seizure risk, and prospective trials would be needed to really explore the issue fully. Again, going back to the theory of the cortical irritation, may not actually be the culprit underlying seizure semiology in post-shunt patients, although it's hard to say that for sure with so many etiologies at play. And in order to really look at that relationship, I think we need larger multi-center studies to look at the underlying etiologies to better study the association. And with that, I'll take any questions.
Yeah, hey Scott, it's Jay. I just want to say you did a really great job with that project. And I think it's interesting to me that, first that we found that our seizure rates were really as low, if not lower, than shunted patients. And the second thing I would say is that you bring up a really good point, which is how many of these patients would be destined to have epilepsy regardless, regardless of the shunt operation, which I think is that's a very hard number to come up with, because there's no real way to study the natural history of hydrocephalus because you have to treat it.
Right.
Any other questions? This was great, and I think that's what Jason Hellman just said is exactly right. How many would have, how many would just the cortical irritation of passing a catheter it needs to be controlled, as we all know. So anyway, great work, Dr. Boop. And without further ado, shall we go to Maggie Jenkins Cooley? Used to be, now it's McGrath, so I apologize, but we recruited her from the University of Washington via Montana, Missoula, Montana, to be exact. She did a sub-I here and impressed everybody, and we recruited her here, and she's giving a talk. Dr. McGrath is giving a talk on surgeon cost awareness. Okay, go ahead.
Thank you, Dr. Ellenbogen. So I'm going to be presenting on a project focusing on health economics and cost awareness effect, like Dr. Ellenbogen was saying, that was worked on with Dr. Segal, myself, and then a few of my co-residents and some medical students. The project was titled Surgeon Cost Awareness Decreases Recombinant Human Bone Morphogenic Protein Dosage and Health Systems Costs for Spinal Arthrodesis Without Increasing Complication Rates. So some background, there are multiple strategies to enhance bone effusion, allograft, autograft. One of these is BMP, so recombinant human bone morphogenic protein, which is a naturally occurring protein that stimulates bone growth, and was proposed initially as an alternate to iliac bone crest autograft. It was initially studied in ALIF procedures, and it's actually only FDA approved for ALIF procedures at this time, but it's very frequently used in an off-label fashion for osteoinduction. Separately, it's really expensive. So the upfront cost to the hospital can range from $900 to over $5,500, depending on your dose. And it's, almost 6 times as much for the patient. And controlling healthcare costs is a primary concern for present healthcare policy. So given the increasing use of BMP, finding methods to reduce the economic burden of BMP without detrimenting patient care is of high yield for healthcare facilities. and spine surgeons. The cost effectiveness of BMP compared with other fusion enhancers such as iliac crest has been studied in the past, but there is a lack of data on BMP cost utilization or on the effect of surgeon awareness of BMP cost utilization and on patient outcome. So our primary objective was to determine whether intraoperative BMP dosing management was altered by surgeon cost awareness. And then the secondary objective was to describe any surgical complications associated with BMP dose changes before and after surgeon awareness of BMP cost. And our hypothesis was that surgeon cost awareness will reduce BMP dosing and subsequent overall cost without increasing observed complication rates. So we did a retrospective medical record review, identifying patients who were greater than 18 who underwent spinal fusions performed at a single institution that by a single surgeon from June of 2016 to June of 2018, in which BMP was used. The patients were identified using DRG codes that included spinal fusions and then filtered for those that were supplemented by BMP. The single surgeon became aware of the cost of BMP halfway through the time period during which the cases were included. And then after becoming aware of BMP, continued to operate without a change to patient demographic or caseload. Cost data was extracted by the UW Medicine financial department. And the outcomes that we looked at were BMP dose used and associated list price, and then expected Medicare reimbursement was calculated for each surgery regardless of actual payer. Complications that we looked at were ones that have been reported in the literature as being associated with BMP, so heterotopic ossification, osteolysis, seroma, wound infection, wound adherence, arachnoiditis, dysphagia, increased neurologic deficits, retrograde ejaculation, pseudoarthrosis as well. For our results, so we included a total of 48 patients and a total of 177 levels that were fused. 16 cases were performed before the surgeon was aware of the cost and 32 after. And looking at BMP dosage, as you can see, the awareness of BMP cost did result in increased usage of smaller dosages of BMP. So prior to cost awareness, the most frequent BMP dosage level that was chosen was extra small, then followed by large, followed by medium, and then extra small was not chosen at all. And then after cost awareness, the most frequent BMP dosage was extra small, followed by extra small. Looking at the cost data, there was also a significant change in the average cost for BMP per surgery. So prior to cost awareness, the dosage choices resulted in a mean BMP cost per surgery of over $4,000, so $4,116. And then after cost awareness, dosage choices resulted in a mean cost for surgery of $2,268, which was a statistically significant 44.9% reduction in the amount spent on BMP. And when we looked at payer data and the expected Medicare reimbursement, we found very similar results. So prior to surgeon cost awareness, BMP encompassed 7.6% of the expected Medicare reimbursement, and then after cost awareness, BMP encompassed 3.3%, so a 56% reduction. Last, we looked at complications. So the mean follow-up time for our patients was 107 weeks. The surgical complications in total are shown here. Of the 48 patients that we included in the study, 40 were included in long-term follow-up, as 8 patients were lost to follow-up. Of the 16 patients before surgery, 1 was lost to follow-up, and 2 of the remaining had complications, so about 13%. And then with this, 1 of these patients experienced a postoperative epidural seroma, which was associated with weakness and required a seroma evacuation. And the other experienced pseudoarthrosis with a rod breakage requiring revision. Of the 32 patients in the post-surgeon cost awareness group, 7 were lost to long-term follow-up. 2 of the remaining experienced what we would call a complication. We included 1 because only one required a revision. So one developed pseudoarthrosis with rod breakage requiring revision. There was also a postoperative seroma that did not affect patient outcomes or exam. So the total pseudoarthrosis rate, which was really kind of the most important that we were looking at with the reduction in BMP, was 6.7% in the pre-cost awareness group and 4% in the post-cost awareness group. This was not statistically significant. And so just given the amount of patients that we had, we didn't have the power to make it statistically significant, but we did observe that there was no increase in pseudoarthrosis rate as we reduced the BMP dose. So in conclusion, surgeon awareness of BMP cost resulted in a preference for smaller, less expensive doses of BMP with a corresponding overall decrease in BMP costs in this cohort, which overall reduced hospital admission charges without increasing observed complication rates, including pseudoarthrosis. I think it really emphasizes the need for additional data on dose-related efficacy and morbidity with BMP, of which there's a number of papers, but still needs to be more data on smaller doses of BMP and the morbidity associated with that. And then you could also look and expand this as how cost awareness affects intraoperative management and overall outcomes in different areas other than just BMP. Important limitations, it was a retrospective design. We had a pretty small sample size. It was single surgeon in nature, limited long-term follow-up as this was at a trauma hospital and our follow-up can be limited at Harborview. And then institutional limitations on publication of private payer data, which we went around by using expected Medicare reimbursement. However, we were limited in actually publishing some of our private financial data at the UW. Thank you to the entire team, Dr. Saigal for his mentorship with this, Dr. Ellenberger, Dr. Durfee, and Jason Barber helped with stats and production, and then my co-residents and medical students that also helped. And that's it.
Thank you very much, Dr. Jenkins Cooley McGrath. That was fabulous, yes, and we're still thrilled we recruited you out of Missoula. Let's ask Dr. Saigal. Dr. Saigal, you could do this with instrumentation. You could do this with anything in spine. Tell me your thoughts about what you expected to find and what you found, and how that should impact our practice.
Yeah, I've always been struck by how little we know about the costs of the things that we put into patients. I feel like in the best of cases, everything we ask for, it'd be like a menu at a restaurant. You know the prices of everything, and if you're using Tisseal versus Duraseal or Durapair versus Duragen or versus something else, that you'd always know the exact price of what you're putting in. But as physicians, a lot of those prices are totally opaque to us unless you ask about it or research it. And I think it really does influence behavior. In this case, it influenced my behavior when I found out the exact cost of these different doses. One anecdote about BMP is that once in a while you'll get a mistake in the package that's opened. And Maggie mentioned those different doses, the smallest one being double extra small, which is 1 milligram. The difference between a nurse opening double extra small, 1 milligram versus extra small, which is 2 milligrams, that's $1,000 with that 1X. And I've had it happen a couple of times where they inadvertently mishear us and open the wrong package. So I'm interested in health economics. I think Maggie did a great job with this project. I think that it's a great direction to study almost everything that we do where there's any implant whatsoever, and to see if cost awareness affects our behavior, and can we get the same results by paying less? Can we get a good result for our patients while costing less to the system? I think there's a lot of opportunities for that. Also, just want to give kudos to Maggie for her perseverance. We started out with this a while ago, and we were getting ready to publish, and then we heard from UW's financial department that they didn't want us to publish because of some private payer information that we had, and we had to kind of completely rework the project. So it's kind of a creative solution to do this with Medicare reimbursement remodeling with the same patients in the database, and ultimately we were able to get it in by reconfiguring the project. So good job, Maggie, for persevering through it.
Rajiv, and we're going to miss you, obviously. So thank you for your mentoring of Dr. McGrath on this. But I absolutely have to agree with you. I asked Jenny Spizo 10 years ago to put up, if we put up on our shelf, just like this is how much a Band-Aid costs, this is how much Tissot costs. If we had that on our shelves, I guarantee you, knowing how frugal some of us are, we could cut 20 to 30% off our costs by using less of everything. Okay, doing things different if we realize this was just as good and cheaper. So I agree. I wish the problem is we find out that what things cost and what the hospital charges are two very different things. So there's sometimes the hospital, it may cost the hospital nothing for a Tylenol dose, but they're charging the insurance company $25 for a Tylenol dose. So they're making profit off certain things. But I agree, in the operating room, if we had how much each shunt cost, how much everything costs, we could cut the costs to the hospital. I don't know why they don't do it, Rajiv. Good point. All right.
Dr. Ellenbogen and Dr. Saigal, a quick question. Do you ever foresee hospitals publishing how much it costs to do a procedure to the patient? Because I think it's one thing for the physician to be mindful of how much something costs, but I think it's even more important for a patient to be able to understand what they're getting into financially and making their decision for whose care they seek based on how much something costs.
So Jake, that's a good question. And that just started our congressperson from the 8th Congressional District of Washington. She's a pediatrician. She authored a bill in Congress of transparency and costs. And now hospitals, in fact, I just got a bill on my aged father, which told me exactly how much things cost, which I never used to get before. It's coming. I think Congress is putting the pressure on hospitals to be more transparent. How they work around that, I don't know. But yes, it's called, I forget what it's called. The congressional bill was transparency in healthcare, or something really fancy like that. But yes, that's going to happen. That's coming down the pike. Thanks for asking, Jake. All right, Eugenia, you ready? So Dr. Eugenia Tertova grew up in Russia, and she is the only one in our program that actually has a degree as a registered nurse. Over a decade ago, what were you doing? Well, she was doing nursing care. She has her bachelor's of science in nursing. She went on, of course, to Yale University School of Medicine, where she worked in Dr. Gunnell's laboratory and distinguished herself there before we recruited her to the University of Washington. So we're thrilled to have you, Eugenia. Thank you.
Thank you for the introduction, Dr. Ellenbogen. Today I would like to talk about the project titled Surgical Outcomes in Adult and Pediatric Craniopharyngioma, Endoscopic versus Open Approaches, which we are just launching around this time, with Dr. Manuel Ferreira being a mentor for this project. I have no disclosures. So craniophryngiomas comprise around 2 to 4% of intracranial tumors. They are more common in pediatric population, comprising around 10% of all the tumors. Majority of them are benign. However, malignant transformation can be present, yet rare. These tumors are challenging due to their location and sequelae of their growth and proximity to the critical neurovascular structures, such as circle of Willis, optic chiasm, pituitary stalk, and hypothalamus. In pediatric populations, these frequently present with hydrocephalus and growth failure. In adult population, they can present with severe headaches, progressive vision loss, and symptoms related to the compression and invasion of hypothalamo-pituitary axis, such as diabetes insipidus, loss of libido, energy, and obesity. Pediatric craniopharyngioma represent pretty much a distinct cohort from their adult counterparts in terms of genetic and clinical pathologic standpoint. Pediatric peak presentation occurs between 5 to 15 years of age, and more common it is adamantinomatous histologic subtype, which thought to arise from a neoplastic transformation of embryonic epithelial remnants of Redkis pouch. They frequently contain beta-catenin gene mutations. Craniopharyngiomas can also arise in, can have adult onset, arising in adults 45 to 60 years old. In this age, papillary histopathologic subtype is more common, which is thought to arise due to metaplasia of already differentiated cells, and majority of them contain BRAF V600E mutation. Craniopharyngioma surgery remains quite challenging, again, because of this tumor's anatomical location and high rates of recurrence. Historically, open surgical resection is, of course, has been the mainstay of treatment, but with the advent of endoscopic endonasal transsphenoidal surgery, it emerges a safe, effective, and minimally invasive alternative, which would provide a panoramic view of the operative field without need of much brain retraction and manipulation, which would provide an ability to dissect the undersurface of optic chiasm and hypothalamic walls under pretty much direct visualization. Radiation therapy, such as a gamma knife and protons, have been reported as a effective adjuvant to the surgical resection. And then there is a number of reports coming up of the new targeted therapies for this tumor, especially the ones containing BRAF V600E mutation. Looking into the literature for these tumors, while pediatric and adult tumor differ so much in their presentation, they pretty much behave similar in terms of surgical outcomes. The superiority of open versus endoscopic approaches remains quite controversial. Different authors reporting different data. There is a large review series by Dr. Komatar of around 3,500 patients that reported that comparing to transcranial group, endoscopic group actually underwent a significantly demonstrated significantly higher amount of gross total resections, exhibited significantly greater improvements in visual acuity, but had a higher risk of CSF leakage. In terms of comparing, looking at the outcomes in terms of gross total versus subtotal resection, there is a nice review from Columbia looking at a total of 1,366 patients, which basically concluded that patients who undergo gross total resection demonstrate recurrence rate of these tumors around 20%, and with subtotal resection, recurrence rate going up to 50%. However, if adjuvant radiation therapy such as gamma knife or protons are added with subtotal resection, the recurrence rate goes down to 22%. So overall, gross total resection presents with more postoperative morbidity, but lower recurrence rates, and subtotal resection with reduced postoperative complications, but an increased rate of recurrence, with comparable recurrence rates after gross total resection and subtotal resections with the adjuvant radiation, which shifts our thinking in terms of surgically approaching these tumors from gross total resection to actually avoiding surgical morbidity and concentrating on the avoiding morbidities that would influence the quality of life. Craniopharyngium project is a prospective multinational randomized study of the patients with childhood onset craniopharyngioma, which precisely focus more on quality of life rather than disease, complete disease eradication, and report that visual deficits associated with surgery and damage to the endocrine and hypothalamic functions actually really influence the quality of life of these patients. Therefore, the goals of our study would be to compare surgical outcomes, including extent of resection, progression-free survival, complication rates, as well as a long-term quality of life between open and endoscopic endonasal approaches for craniopharyngiomas in adults and pediatric population. And our study is going to be a retrospective chart review looking at the UW patients as well as Seattle Children's and Harborview. We'll be looking at all the patients who underwent resection of their craniopharyngiomas, either total, subtotal, first time or recurrent, and we still working on comprising the database. We have around 70 patients that we have already identified, and we expect more to be added. Actually, one major problem with most analysis in the existing literature is the lack of reliable information regarding long-term prospective hypothalamic disturbances and ophthalmological outcomes. It's worth noting that at our institution, there is a close collaboration between neurosurgical, endocrine, and neuro-ophthalmological specialties in our pituitary program, which gives the access to reliable, consistent, and longitudinal data. So our methodology for this project will be based on correlating the radiographic and clinical pathologic tumor characteristic, patient variables, and specific surgical details with immediate postoperative complications and long-term surgical outcomes, such as overall survival, progression-free survival, evidence of hypothalamic visual outcomes, and quality of life measures. So more data will follow after we get the study launched. And I would like to thank Dr. Ferreira and all the residents and medical students participating in this project for getting it on the ground.
Thank you, Eugenia. Questions are very nicely done. Any questions for Dr. Turtova?
Eugenia, why don't you do this prospectively?
That is a good idea. I think after reviewing retrospective data, we can definitely look into launching a bigger prospective study as well.
Thank you. All right. Without Dom, are you ready? Thank you.
Dom is just finishing up a phone call. He'll be on.
Okay, well, we can, do you want to go to Zach?
Hi, sir.
Oh, Dom, there you are. Okay.
My apologies.
No, you don't have to apologize while you're working as a physician at the University of Washington. Never apologize for doing patient care. So Dom, Dominic Anthony Nistel, what a regal name that is, grew up in New York. He went to school, he had a little detour, another Hopkins guy, only he majored in neurosciences, if I remember correctly, and then went off to Icahn School of Medicine at Mount Sinai, where he was heavily recruited all over, and we were fortunate enough to get Dom. So Dom, tell us what your research you're doing, and we're thrilled to have you here. And go ahead, share your
Absolutely.
screen.
Thank you, sir. Sorry, just sharing my screen 1 second here. Excellent. Can we see that okay?
Yes, we can. Beautiful.
Great. So I wanted to talk a little bit about
boundless. I like that. Thank you.
I want to talk a little bit about the work that I did at Mount Sinai and then transitioning here to UW. The work that I've been trying to begin and start with Dr. Levitt and Dr. Kim and the entire SANS group, and kind of the overlap in the projects that I had at Mount Sinai and here, and the stuff that we're starting out here, which I'm really excited about. So for those of you that remember from my sub-I conversation, I performed a study with Dr. Kellner and Dr. Mako at Mount Sinai, looking specifically at biomarkers and discovery of biomarkers in intracranial aneurysms with the goal of developing a multi-omic signature for pre-rupture discovery of aneurysms. Just in the background of, as we all know, that pre-hospital mortality for ruptured intracranial aneurysms and subarachnoid hemorrhage is quite high. And if we were able to develop some kind of, in the long run, blood test or pre-hospital identifier for the presence of an intracranial aneurysm, we could provide treatment for these patients prior to the devastating disease that is aneurysmal subarachnoid hemorrhage. And so that project, just to kind of review what we did, it was a prospective pilot study. We looked at 28 patients with intracranial aneurysms and then age, sex, and comorbidity match controls for the purpose of detecting the presence of an intracranial aneurysm. We used a platform called Olink proteomics, and so looking at different proteomic analytes for the discovery of a biomarker for these patients. We performed multivariate regression analyses as well as some support vector machine learning algorithms to determine a signature for discovery of intracranial aneurysms. This is just one of the figures, and this is a heat map looking at the expression across the different subjects. On the left side of the screen is the entire subject population and looking at all of the analytes in which we looked at. And then on the right is the signature that we were able to develop. The orange patients at the top being those without intracranial aneurysms, and the patients on the right that are listed in purple at the top are those with aneurysms. And you can see that there's a clear expression difference in profile from this patient population. And so that was something that was very exciting to us. And so my hope was to kind of transition that here and use some of that at UW for the work that we're doing in the SANS group. Looking more at the support vector machine learning algorithm, we developed a testing and then we developed a support vector machine learning algorithm where we stated, could we identify which patients had aneurysms, which did not, just based upon knowing this proteomic signature of 8 analytes. And we showed that the area under the curve here was quite significant with a high sensitivity and specificity for detection of intracranial aneurysms. And so bringing it back to the work here at UW and my hope to transition some of this type of data analysis to the data that we're going to collect here with one of the exciting projects that Dr. Levitt and Sam Levy and the entire SANS group has developed is a study looking at stroke biomarkers in patients undergoing surgery for aortic arch surgeries for aortic aneurysms as well as other pathologies. And the goal here is to identify a biomarker for stroke in a very unique model that I think has never truly been explored for this purpose. The patients undergoing this surgery undergo deep hypothermic circulatory arrest, which is a state in which we can take a patient who pre-surgery has had no strokes, no intracranial pathologies, just cardiac disease, and then look at their postoperative course where there's been data to show that 100% of these patients in one study with hemi-arch replacement had positive ischemic lesions on MRI postoperatively. And across the board, these patients that undergo this type of surgery with hypothermic arrest, 3 to 5 patients will have clinical ischemic strokes after the surgery. So it's a quite unique in vivo model to look at for stroke in patients. And so the study that was developed by Dr. Levitt and his group is a pilot study to examine for peripheral biomarkers before and after aortic arch surgery. The study group is looking at those with the circulatory arrest and aortic arch surgery versus those undergoing open heart surgery without this type of arrest. And then also looking before and after surgery. We look at multiple time points for each of these patients and collect serum, plasma, urine, and saliva from all these patients at each of these time points. as well as obtain a post-surgical research MRI, and as well as a neurologic exam at that point, as well as post-operatively and the time of the MRI with an NIHSS score. And currently we've enrolled, I think, just over 10 patients, and we've already seen clinical events of ischemic stroke, and I think the data will be really exciting, and we're really looking forward to seeing if we can identify a clinically significant biomarker for ischemic stroke in this population. And then I wanted to talk a little bit about one other project that's ongoing as well. And so at my time in New York, one thing that I was heavily involved in and was interested in was minimally invasive endoscopic ICH evacuation, which we perform here at UW as well with Dr. Levitt. And there's a number of trials, as many of you I'm sure have heard of, the MISTY trials, the ENRICH trial, the MIND trial, that are ongoing for looking at this. I've attached a figure here from one of the meta-analyses of minimally invasive evacuation for ICH, looking at the benefit compared to other treatments, which would include open craniotomy or medical management. And this recent meta-analysis showed that there seems to be some leaning towards benefit in the literature that maybe minimally invasive evacuation of these intraparenchymal hemorrhages be beneficial for long-term outcomes in patients. So that's what kind of initiated a lot of these trials that are ongoing. At Mount Sinai, we are particularly working on they're working on the MIND trial, and Dr. Jay Mako is the site PI and national PI for the study. And we developed a technique called the scuba evacuation technique, and this is an image from that paper in which we do a very similar approach here at UW, where we do an eyebrow incision, go along the length of the clot, and are able to aspirate the clot out, and then we would infuse saline to then maintain the walls of the clot to look for any active bleeding vessels. And the evacuation percentage in our initial series was 88%. And then we further looked at long-term outcomes in this series. And here we show that long-term functional outcomes in the Sinai group with minimally invasive endoscopic evacuation for these patients was as comparable to the MISTY group, if not better, for long-term outcomes after the surgery here. And so a lot of this work got me excited about our series here at UW. And so I worked with Gil Barros and Dr. Levitt here to look at our series, although only limited to 31 patients and 32 procedures. We here show some of our initial outcomes and findings. And one thing that was notable was that the location of the clot, which is what we found also in our Mount Sinai series, which is found in the MISTY trials, as well as that the depth of the lesion being deep lesions have much worse outcomes than lobar lesions. But we weren't able to find anything significant in evacuation percentage or pre or post-op volumes with long-term functional outcomes, although limited to our series being a little bit younger and having only 30-day outcomes and not 90 or 180-day outcomes yet for long-term functional outcomes. And here, this is, again, a small sample size, so something that's an analysis that we were just kind of experimenting with, but looking at a multivariate regression and seeing that percent of volume reduction we have yet to find to be significant for long-term functional outcomes at 30 days, but hopeful that with a larger sample size and longer-term functional outcomes, we'll see some development. Thank you, guys, and thank you, everyone, for the opportunity to present, and I'm happy to take any questions.
Great, energetic, and I'm glad that you brought some of your projects from New York City here and they transported well. Any questions for Dr. Nistel? If there are not, last but not least, am I correct, Sylvia? Zachary, usually he's used to being the first one because of the A, but we thought we'd mix it up a little. Now, Zachary has an interesting background. He got his undergraduate degree at Northwestern in industrial engineering and management sciences. So that's interesting. And then he spent 4 years before he went to medical school. He worked at Accenture Strategy, which was a management consultant corporation. And then he started, like Lynn McGrath, he started his own company called Z Abacasis Consulting. And so a little outside the box. Thank you, Zach, and we're thrilled to have recruited him here. Zach, tell us what you were doing.
Hi, good morning, everyone. Thank you again, Dr. Ellen Bogan, for the opportunity. So when I was on my second month at UW, I started working with Dr. Hofstetter on a study to evaluate the cost effectiveness of endoscopic spine. So just a brief background on endoscopic spine. There's been a shift in medicine in general, and especially in a lot of surgeries, to decrease morbidity to patients. And in the context of spine, it's been to try to have more minimally invasive approaches, which has been shown to keep patients in the hospital shorter duration. It's been shown to have less inflammation and less complications. So this is just a quick depiction for those who aren't familiar with the two main types of endoscopic spine surgery. You could do an interlaminar approach or a transforaminal approach. And then below is just a nice qualitative image of kind of the complexity of various spine procedures. So you can see, it starts with discectomy all the way to instrumentation, and then the benefit of and it kind of cut off a little bit, but it says like invasiveness and complications. As you can see, for non-instrumented procedures, there's definitely an area for endoscopic spine to benefit the patient when it comes to both invasiveness and complication. And for those who have not seen what it looks like to do an endoscopic spine surgery, these are kind of the two different approaches. So the top picture is just a picture of the interlaminar approach, and then the bottom picture is a picture of the transforaminal approach. And this is just a close-up of the actual endoscope. You can see the camera and then a few ports for instrumentation. So, and there's already been, it's been well studied and well documented that, MIS versus open, there's a lot of opportunity to utilize MIS over open to help the patient, and some of the things that I spoke about: length of stay, estimated blood loss, complications, and overall morbidity. There's now been more of a shift towards trying to evaluate endoscopic spine versus MIS. And here is a nice table that I put together for the paper, but just to summarize it, because it's very busy, there's been shown, and it's been well documented from papers actually out of this institution, from Dr. McGrath and Dr. Hassan, studying length of stay, inflammatory markers, various disability indices and pain scales, and complication rates, that patients do really well with endoscopic versus MIS. The one caveat that's been highlighted is that it is a steep learning curve to endoscope is an unfamiliar instrument to a lot of neurosurgeons. So we've seen that the length of operating time is increased in these. What we wanted to focus on was more so, we understand that there's benefits, but how does the cost relate? And then if you look at the cost, you can evaluate the overall quality of care. And based on where healthcare is transitioning to, the value of care provided to the patient is becoming more and more important. So we thought that this would be an important thing to focus on. So what we did is a retrospective review of patients that underwent MIS laminectomies and discectomies versus endoscopic. And we looked at two major surveys that these patients fill out. So one was the ODI, which is basically looking at the various functionalities of the patient and how they would limit their pain and their disability. And then visual analog scales is basically just a scale of 1 to 10 on how much pain the patient is in. And we did this both at the preoperative mark and then the 1-year mark. And then we collected both direct and indirect costs, direct costs being defined as the actual cost of the surgery, and then indirect costs would be all of the costs associated with the patient's stay. For example, any tests or any ancillary stuff that would be included in that. And then finally, we went through kind of the basic metrics of the patients that you would collect for any retrospective review. The results were pretty similar for cost. So I think there was a larger variation in cost for MIS cases. And then the length of stay was about a day shorter for endoscopic. And actually, just anecdotally, based on what I've seen in my few months at UW, is for most of these patients now, they're going home the same day. So I imagine if we were to repeat the study with data that we have now, it would be even shorter. And then for looking at the measures were relatively similar. I think that there was a little bit of a better result for the endoscope. If you look at the pain scale for the for legs, and then also for ODI. But generally, also, I think there was a trend for patients with receiving an endoscopic spine surgery that they typically had a little bit less of a disability and pain to start out with. Then we evaluated the cost effectiveness, and how we defined this was essentially looking at the total cost, which is the two buckets that we talked about, and then taking kind of the incremental improvement that the patient saw by looking at their preoperative and postoperative evaluations of their pain and disability, and then basically using the pre-op as the benchmark. And what we saw was that from this metric, that endoscopic spine actually had a significant advantage over MIS in all three categories. So the conclusion that we can draw from this preliminarily is that, based on these quality of life outcomes and from the cost, that there's a lot of potential for a cost effectiveness with endoscopic spine surgery, especially as surgeons become more trained on this process, because I think that it's still only done at a few institutions, becoming progressively more popular. I would imagine that we would see the operative time decrease, which would further increase the value based on the cost of operating time. We're getting ready to submit this paper. We just have to do a few more things. I think we want to do a little bit more statistical analysis on this. So we want to really break down both on univariate and multivariate analysis and get an understanding. And then one thing I wanted to look at was try to dig a little bit deeper into the costs. My background's in management consulting, so I'm always thinking about the bottom line. And for this, trying to understand kind of where the differences are arising from. But it was a very exciting project, and I'm very thankful to Dr. Hofstetter and the rest of the UW faculty for the opportunity to present this research, and then also to participate in this study.
Dee, that's great. We're great to have you here. Let me ask if Dr. Hofstadter's still on the line and he can comment. Anything?
Yeah, no, I'm still here. Even though my patient is already on the bed, it's actually an endoscopic patient, a patient with a BMI of 55 that we flew in a special endoscope with disc herniations that are central and obliterate the entire canal. So I think, Zach, thank you so much for your help. And I think you did a terrific job in summarizing this. We have had terrific, impact with our work here, especially Asia Pacific. And there's, our protocols here have been really taking one-on-one from this. And I think in the US, these type of data will make a true impact. What we have seen here is, despite our very sick patient population, we can maintain our complication rate very, very low. And as I'm wrapping up here, we just actually looked at all of the complications that we have at the University of Washington. With a 12% rate of immunosuppressed patients, our complication rate is 3%, which I'm very proud of, I think, to conclude like that. So I think this is for sure the future. And I think you've really, with this work, you really contributed nicely to that. So thank you.
Thank you, sir. Appreciate it.
Thank you. Let me just make a comment on all the talks. Really superb. I love this symposium. You all did a wonderful job. I want to thank all the faculty mentors. You have been inspiring to these young residents, and I appreciate that.